All right, today we're going to talk about intussusception. These are some of the risk factors that are related to gastrointestinal disorders. So any of the gastrointestinal disorders that a child could be born with or develop over time are usually related to these risk factors. So prematurity, because their gut is not fully functioning at birth when they are born on time. So it's definitely not functioning fully when they are born early. A family history of gastrointestinal disorders. Different genetic syndromes put a child at higher risk for developing or being born with a GI disorder. Chronic illnesses. So if a child is chronically ill and they are on antibiotics on a regular basis, we're basically ruining their gut flora. And this is how we end up with C. diff. There's different prenatal factors that come into play for the different genetic GI disorders. I'm sorry, not genetic GI disorders, but GI disorders when you are born. And different exposure to infectious agents. We've like Giardia or Campylobacter or Shigella, different viral processes like norovirus and rotavirus. Foreign travel is a big risk factor, as is immune deficiency and chronic steroid use, as well as chronic antibiotic use. All right, so with intussusception, we see that it usually occurs in a relatively healthy child, usually under a year old, but it can go up to about age 5. It is definitely more common in males than it is females, and we basically see a telescoping of the proximal segment of the bowel into a more distal segment of the bowel. So it kind of collapses in on itself, sucks in on itself an entire segment of the bowel. This then leads to edema, which then causes compromise to the blood vessels. And when there's swelling and compromise to the blood vessels, then things aren't moving as they should be moving, and it leads to bowel obstruction, and then we develop pain. Pain, vomiting, and these are the two Inclex pearls that go along with intussusception, and that is a sausage-shaped mass in the upper mid-abdomen and currant jelly stools. And I'm going to show you on the next slide what a currant jelly stool looks like. You can literally Google currant jelly, and yeah, that's what the poop looks like. Some of the cues that we'll see in a child that presents with intussusception is intermittent severe pain, possible screaming, they're drawing their knees up to their chest. It's difficult for them to breathe because of the pain, and frequently they pass out. We do need to be aware of their airway. They become quite lethargic from dealing with the intermittent bouts of pain, which, if you think about it, is caused because of the telescoped portions of bowel. When the portions of the bowel are trying to move with peristalsis and it's stuck inside something else that's preventing the peristalsis from happening, it's going to cause massive pain. So every time they have peristaltic movements, they have severe pain, which is why it's a very intermittent presentation. In between the massive pain, they could act completely normally, playful, plenty of energy, doing just fine. Then the pain happens. It lasts for a minute or two, maybe longer, and they get very uh, almost like they're, yeah, going to pass out. And in this slide, I'm showing you what the current jelly looks like. That is literally like a little mason jar filled with jelly. It's a very red, viscous, slightly mucousy looking jelly, and that is what we will see in the stool. Frequently found in the diaper by the parents, and that's what prompts the visit to the hospital. You can see here that the area of the ascending colon is usually where it happens, and that's why we have the sausage-shaped mass on the upper right side. Because if you remember from your anatomy and physiology, your descending colon's going down the left. So the ascending colon happens to be where it occurs at most frequently. It sucks up into itself. It creates ischemia again because of the edema, the lack of blood supply, vascular compromise, and then bowel death. You guys who have ever seen one of these, I think they were called water willies, and I remember them from my childhood. You squeeze it and it just keeps squirting in and out. This reminds me of what intussusception probably looks like, because this is a tube that's encapsulated upon itself. So water willies and intussusception, they go together in my brain, so I'm making it go together in yours. All right, so the hypotheses related to intussusception, obviously, I think severe pain needs to be one of them. Dehydration is another. When the child is in a massively painful state, arising from their guts especially, they're not going to want to eat or drink. So if we have a child that's under age 3, they're frequently getting formula, well, under age 1, but this can occur anywhere from 3 months to 3 years old in a typical presentation, and slightly older up to 5 or 6 years old in an atypical presentation. So a diapered, bottle-fed child is going to become dehydrated pretty quickly, A, because they're smaller, B, because they have more water relative to their body size than an adult, and also because they are refusing to drink. We're going to have ineffective breathing as a hypothesis, because these kids are frequently going to be holding their breath to the point that they pass out because of the pain. And then they're also developing pressure on the lungs by the buildup of the stool and mucus and swelling that's occurring in the upper right part of the abdomen. So the medical management, sorry, you're hearing my Roomba come on. The medical management for intussusception it goes by the rule of 3s, which basically says you get 3 attempts as a physician because it is a medical emergency. So the rule of 3s is you get 3 attempts to clear the intussusception. 3 attempts, each can only last 3 minutes in duration, and the saline bottles used for the enemas should be at a 3 feet height. This was when they frequently used enemas to treat an intussusception, assuming that the pressure from the enema squirting in from the bottom is going to push the bowel off of itself and straighten it out. They don't use this method very frequently anymore. So now it's kind of the rule of three is you can try it with an air enema. If the air enema doesn't work, you can try it with a barium enema. If the barium enema doesn't work, the child needs to go to surgery. So here's a really good, clear picture of the intestine telescoping up into itself. So the picture that you're looking at on your screen that's on the left that has the obvious pink appearance and you can see the mesenteric fat around it, that is intussusception. That is a segment of proximal bowel that has telescoped up into the distal bowel in the ascending colon. So that's what it looks like when they're going in to surgically repair it. On the right-hand side of your screen is what's called a malrotation or a volvulus, and that's basically where a portion of the intestine twists until it blocks off the blood supply. We can treat both of them with air enemas. Here's a link to my very favorite video of an air reduction of an intussusception using an air enema. It's really interesting, and the doctor does a really good explanation of his findings, and the mother is very descriptive with the cues that she saw prior to bringing the child in. Okay, so the nursing management of a child who has an intussusception, like I said, it is basically considered a medical emergency because the loop of bowel that is trapped in itself is going to die and the child will become septic and they will have a very bad outcome. So when we see them in the emergency room and the intussusception has been viewed usually by ultrasound or KUB, we're going to start as the nurse preparing for an air enema as well as the possibility of a surgical intervention, because if the air enema does not work and the barium enema does not work, then they have to have surgery. So we want to make sure that while everybody's still awake, breathing, and healthy, that we get consents, that we have all of the equipment that the physician might need to be able to perform the air enema, and we want to make sure that the child stays in PO while we're waiting to start that procedure. Usually they've been in PO because taking in anything by mouth is causing, peristalsis, and that causes a lot of pain. But we have to make sure. So need to be in PO, even if all we're doing is the air enema or the barium enema, just to make sure, just in case we have to go to surgery. We're going to monitor their vital signs before, during, and after the air enema. Part of the reason why this is very important is because we need to see if there are any impending signs of bowel perforation. Because if we are basically puffing up in a child's insides with air from below, we could pop it. So we want to watch out for that. We're also going to be monitoring for other cues related to bowel perforation. So an increase in pain, lethargy, maybe even potentially a resolution of pain for a minute, and then it gets worse from there when the bowel contents start to leak out. After they've had the air enema, if it goes well, and even if it didn't and they ended up having to go to surgery, the thing that we want to be monitoring in these children is the consistency and character of their stools, as well as any return of the intermittent pain. So we need to do a very careful pain assessment based on the age and the cognitive development of the child. We need to monitor for the consistency and character of the stools, because if we start seeing more current jelly type stool or bloody discharge, it's a possibility that the intussusception has not been reduced all the way, or that it is recurring. So we want to make sure we watch for that. And that's it on intussusceptions.